So in this video, we're going to look at the assessment of the acute spinal cord patient. And it's actually consolidating some knowledge from other videos, which I've listed in the description for this video. And it involves a quiz, so you can work out how good your knowledge is. We're going to look at the differential diagnosis, how to prognosticate, because that's by far the most important, and how to manage really from a general practitioner first opinion point of view. So in previous videos, I've talked about the 7 steps for assessing the acute spine, and I've also had videos on different types of intervertebral disc disease and their management. But in this video, we're going to introduce an interactive component to it and also talk about trying to put that all together and management of these cases with a focus on what happens in general practice rather than referral practice. So first, I'd like to remind you about the grading of spinal cord injuries. We often use this sort of 5-point system, which makes communication between colleagues a little bit easier. So grade 1 is where they have pain only, spinal pain only. Grade 2 is when they're weak but can still walk. Grade 3 is when they are not able to walk. They're either non-ambulatory paraparetic or paraplegic. Grade 4 is when that injury is more severe, so they now have a neurogenic bladder. And grade 5 is where they have lost deep pain perception. Now, if you've lost deep pain perception, then by default, the animal will be paraplegic. There are no loss of deep pain perception is still running around. If that's what you think, then either the animal has an extremely rare, and we're talking about hen's teeth rare, sensory neuropathy, or you haven't assessed deep pain perception properly. By far, the more likely is the latter. So going through all of this, the first important step is that history is important, and particularly for spinal cord problems, then the speed of onset and progression is very important. So what is the timeline, and is it peracute versus acute versus insidious, and has it been static versus progressive? And I'll give you a few examples with spinal cord disease here. Animals that have had trauma or a vascular insult to the spine, such as a fibrocartilaginous embolism, will have a peracute onset. And then things will either stay the same or usually get better, unless in the case of trauma there is some instability there. And so in the case of a vascular event like fibrocartilaginous embolism, there isn't a progression beyond the first few hours. And so this is something that is really quite typical with these diseases and non-variable. So you will not have a progressive course with an infarct or a fibrocartilaginous embolism. An acute disc protrusion, by virtue of the name, is usually acute onset as well, but it can be peracute, but often it can be progressive over a number of hours or possibly days. And again, most of those animals managed conservatively will actually make some sort of improvement over time. Again, there are exceptions if you get more disc material coming out. By contrast, a meningoencephalomyelitis of unknown origin, which is what that MUO stands for, is typically progressive over a short course, usually days to weeks, becoming more and more severe. Whereas neoplasia often has an insidious onset and is progressive over a more chronic course. Although it should be said that if the spinal cord's ability to compensate is completely compromised, then you may see a chronic course, then a very acute deterioration with those cases. So you need to establish how quickly did it come on, whether or not the animal has remained static or whether there has been a deterioration or perhaps a slight improvement. So here is our first interactive bit. Which spinal cord disease are pure peracute during activity? So our choices are here. A, is it an acute compressive hydrated Nucleus Pulposa Extrusion. So here we see a compression of the spinal cord with normal Nucleus Pulposus, and you can see a reduction in the disc there. If these names are not familiar to you, then I commend to you the little video on different types of disc disease. Could it be acute non-compressive Nucleus Pulposa Extrusion, which is ANNPE, or as I prefer to call it because it makes a lot more sense, a high velocity, low volume disc extrusion. So we can see again a reduction in the Nucleus Pulposa signal here in this MRI scan. Spinal cord is coming along here, and we can see an area of high signal in the spinal cord here. Could it be a fibrocartilaginous embolism? Again, a reduction in that integrity of that disc there, and we can see a lot of high signal that is beyond the region of the disc. Could it be discospondylitis? This is an early discospondylitis. Here we can see narrowing of the disc space and a little lytic lesions are on the end plate. Could it be an acute disc extrusion? So we can see a calcified Nucleus Pulposa here with a blob of disc material coming out into the spinal canal. Or could it be a vertebral tumour and fracture? So this is a tumour in here, and this is a fracture. Meningoencephalomyelitis of unknown origin, MUO here, with high signal in the spinal cord here and in the brainstem here. So these animals had no signs before, peracute during activity. Which ones do you think it is? Pausing so you can write this down or verbally think it. There's more than one answer. So the correct answers are A through C. Acute compressive hydrated Nucleus Pulposa extrusion, non-compressive Nucleus Pulposa extrusion, and fibrocartilaginous embolism. Acute disc protrusion is also possible, so our one here. It may be associated with exercise, but typically the signs develop over hours, so it's not as peracute as these other ones here. Yes, some of you may have put vertebral tumour and fracture because the pathological fracture may result in a peracute deterioration. However, this animal will have had signs of pain before. Discospondylitis, a very painful condition, but not peracute during activity. Meningoencephalomyelitis of unknown origin, again, not peracute during activity. So I'd like to remind you that the most useful neurology kit is not an MRI scanner. It is simple equipment that doesn't cost very much. Our next step is whether or not there's spinal pain, which is assessed usually either going from front to back. I typically go from back to front, however. So my next interactive question is, which of these diseases, we've seen them already, are painful? And I won't go through all of the different types again because I have them in this slide here. So when I'm talking about this, I said spinal cord diseases, and that's an important aspect here. So I'm talking about animals that are presenting with acute onset paralysis or weakness and are also painful. Okay, so our answers are A, somewhat. They're usually very painful in the first 24 hours, and then this pain resolves. They improve rapidly with that, perhaps more than you would expect given the pain relief that you're giving. So they rapidly become comfortable. Classically, acute non-compressive nucleus pulposus extrusion and fibrocartilaginous embolism, because they are damaging inside the spinal cord where there aren't nociceptors, then these are non-painful. I've put discospondylitis here as not the correct answer because it's not a spinal cord disease. It's a vertebral body disease. And unless there's empyema, which is actually very rare, then these animals will not have acute onset spinal cord disease and be painful. It is a very, very painful condition, but the animals are presenting with spinal pain only. So the correct answers are acute disc extrusion and vertebral tumour with fracture. Meningoencephalomyelitis of unknown origin. Some of these are painful and some of them are not. It depends on the meningeal involvement, most likely. So if our most top two differentials would be acute disc extrusion and vertebral tumour, we might put this one in on the list depending on how the animal progresses. If they're, these would be much further down the list, and this one would be on the list, but below the others. And this one wouldn't be on the list unless the animal doesn't have any other neurological deficits. So our next step is, can the animal walk? And if they're non-ambulatory, are there limb movements? And so we can see in this little pupster here is dragging himself. And we're just supporting the dog here. Just note, I don't normally use the tail to support dogs. It's just purpose for the use of the video. Normally we would use a hand under, and we can see that there is some sort of movement with this animal, but actually this animal is legs are either flapping in the breeze, or there is already some spinal walking going on with this dog because he had no deep pain perception. We also want to establish if one side is worse than the other. As we can see in this dog here, when we support the dog with a harness, we can see that the right limb is very much stronger than the left limb. This dog is very asymmetrical, markedly asymmetrical. And that informs us with our differentials. So my next interactive part of the quiz is, which acute spinal diseases are often markedly asymmetrical? Giving you your choices just exactly as before. So our correct answer is, I'm sorry, this seems to have become a bit corrupted here, so not looking quite as beautiful. Our correct answers is B and C. So acute non-compressive nucleus pulposa extrusion often affects one side of the spinal cord more than other, and fibrocartilaginous embolism. So these are the, or any other type of ischemic myopathy. And actually the dog that you saw there, the German Shepherd, had a presumed embolization related to angiostrongylus lungworm infection. Acute compressive hydrated nucleus pulposa extrusion. It's more likely to be lateralized in thoracolumbar than cervical. So you may see some markedly asymmetrical signs if it's a thoracolumbar one. Most disc disease, usually one side is worse than the other, but it's not usually markedly. Discospondylitis, as I've said before, is not a spinal cord disease. It's a vertebral body disease. And vertebral tumour and fracture usually would affect both sides. Meningoencephalomyelitis can again be lateralised, but not markedly so. So if the dog is non-ambulatory, our next step is if there's deep pain perception or not. So we see in this guy here, now this is a real life example. So we can see here the dog is quite agitated, but is he actually got deep pain perception? Is there a behavioural response, or is the dog just generally very anxious because of the situation that he's in? It's perhaps difficult for this operator to tell. And so one thing is to test the limb that we know is normal. Don't have the sound on, but this dog yelps at that particular point there, and we know that's very, very different from the response in the dog's pelvic limbs. So again, although the dog is quite agitated and someone called the dog there, we can't see that they actually make a behavioural response to the pelvic limbs. And that's another thing, is to distract the dog. But there's no way that the dog should be distracted. And that was a dog yelping as well. And remember, of the thoracic limbs, and remember that the tail is very important. And they may have some deep pain perception in the tail, but not in their pelvic limbs. And that is actually a very good prognostic sign if they have any kind of nociception. Why is that significant? Because this is talking about the integrity of the spinal cord. So the response has to come from the head end of the dog. So we can see in this dog, I'm pinching the toe, and that the dog has a withdrawal reflex. That's just a reflex. We can also see from the dog sort of struggling that they have a behavioural response. And the reason why that's important is that the nociception can ascend the spinal cord by many and various different routes. So the top and the bottom and the side of the spinal cord. And so if the animal truly has no deep pain perception, then they have a very severe damage to their spinal cord, and that is important from a prognostic point of view. So don't confuse with the flexor withdrawal reflex. That's just a local reflex. You're only assessing the integrity of that sciatic nerve and the local spinal cord, and it's possible that that reflex will be present if the animal has a completely severed spinal cord, if that spinal cord is severed in the T3 to L3 region and when they've recovered from the spinal shock. And so that is completely different. So my next question to you is, which of the following statements about deep pain perception is true? That the prognosis in the acute thoracolumbar spinal cord with absent deep pain perception, whatever the cause, is hopeless. That the prognosis is hopeless unless they're referred for surgical management within 24 hours. That 60% of dogs with acute disc extrusion recover deep pain perception and ambulation by 6 months after injury. Or the prognosis for dogs with absent deep pain perception due to fibrocartilaginous embolism or non-compressive nucleus pulposa extrusion is excellent. Which of the following statements is the most true? Yeah, it's a bit of a difficult one, this one, isn't it? The answer is actually C. So it's not hopeless, whatever the cause. It is hopeless, however, if the animal has had a spinal trauma due to a road traffic accident. It's very unlikely those animals will ever walk again. But if it is disc disease, then about 60% of those dogs will recover deep pain perception and ambulation 6 months after injury. And actually the jury's out whether or not they absolutely need to have surgery for that, because recent studies out of Cambridge University have suggested that at least dachshunds managed non-surgically can recover deep pain perception. It's more difficult maybe with other breeds, because certainly some of those breeds like French bulldogs will also have problems related to their breathing, which can affect their prognosis. So that means that actually when we do all of these animals have to be referred for surgical management? Well, ideally, yes, but in this economic crisis, that's not always going to be possible. So it may be worth managing conservatively and seeing what happens if the animal is able to support that. However, if they have a fibrocartilaginous embolism or acute compressive nucleus pulposa extrusion, then the prognosis is not so good. Our next step is to assess whether or not there is a neurogenic bladder, and that's simply to assess whether or not we need to manage that neurogenic bladder by expression or perhaps placing an indwelling catheter. So moving on to management, should we refer or not? cage rest or surgical management? Well, certainly with grade 1 to 2, I will suggest that they are managed non-surgically initially. And whether or not you manage surgically or not often will depend on owners' finances and other availability of other tests. I mean, if the animal is more severe, it is certainly worth trying to establish a diagnosis, because there may be other treatment options. For example, when meningoencephalomyelitis of unknown origin, putting them in a cage is not going to actually help them, and they need other treatment. But if the case is very classic for a disc extrusion, then even managing them non-surgically with a grade 5 may have some success. So the question is, should you do diagnostic imaging? Well, I would argue that this is useful. However, it's often quite expensive for the owners. I mean, sometimes the costs of radiography, taking a radiograph, is actually very similar to taking a more detailed radiograph, and that is a CT. And I think the problem is that spinal radiographs can actually be very difficult to interpret. And this is one example. This was the spinal cord tumor, vertebral body tumor that you saw fractured earlier. And this is the radiograph that the local vet obtained. And the local vet missed the tumor sitting here, which is quite obvious, I think, when I point it out as a lytic lesion in the vertebral body. But ask yourself how many would have spotted that without further training. And so this is when I spotted that on the radiograph that the vet took. The dog had acutely deteriorated. I took another radiograph and confirmed that the dog had had a fracture. The dog was non-ambulatory and a great deal of pain, and so the dog euthanasia was recommended at that point for that dog without further tests. But one could argue that if the vet had made the diagnosis in the first place, then the animal would not have been needed to be referred or go through that further deterioration. I'm not being critical of the vet, because what I'm saying is that these spinal radiographs are difficult to interpret. So be careful before you charge your owner many hundreds of pounds or dollars. With this one, the vet obtained the radiograph and saw these calcified discs and made a correct assessment that disc disease was more likely. However, told the owner that these were the discs causing the problem, when in actual fact it was this disc that was causing the problem, where there isn't a calcified disc, because this is where the nucleus pulposa is actually sitting up here in the spinal canal, but you can't see it because the ribs are overlying that region, because the dog has not been tilted enough to be able to see that particular vertebral foramen. Again, I'm not being critical of the vet, because this is difficult. You would have to actually take a slightly oblique view to be able to see this in this barrel-chested dog. Some animals do not need to be managed surgically, and that is the hydrated nucleus pulposus extrusion, the acute non-compressive nucleus pulposus extrusion, the fibrocartilaginous embolism. And in those instances, the diagnosis is supported by MRI. And for these animals, there is an advantage in not having a diagnosis, because crate restriction is not required, and they do need to have physiotherapy. And these are more common in non-chondrodystrophic dogs and are peracute during activity, as we talked about earlier. And so, again, it can be an advantage in these dogs to have a diagnosis, but you may be able to offer a very intelligent guess because of being peracute during activity, and as I've said before, being non-painful and being markedly asymmetrical, and that may be able to inform a better choice for that owner. So, when to recommend surgery? Some of you may have seen this flowchart before. If I think that the dog has disc extrusion, acute disc extrusion, then we recommend 2 weeks of crate restriction. Now, crate restriction doesn't mean complete restriction within a tiny area that they can't even turn round in. they really need to have a big enough area that they can have all of their resources in that cage and be able to turn around comfortably. Otherwise, they're going to do themselves an injury just because they're completely immobile. And there are good resources that can talk about how what sort of crate is required, including a rather good book which can written by a physiotherapist vet. So in this, there's really three ways it can go: improvement, no improvement, and deterioration. So in those instances, if the animal is improvement, then we're going to continue to restrict their activity. Obviously, we're going to be giving analgesia as required, and I will try to reduce it at this stage at 2 weeks, because my argument is that if the animal is going to be in persistent pain, then they have a persistent compression of that nerve root or spinal cord, and this is going to much more likely to require surgery at some stage, and I'd rather do it sooner rather than later if that's the case. And then we will gradually return to function over 4 weeks. If there's no improvement, or if they're painful, I'll consider surgical management. And if they deteriorate, then again, this is a recommendation for surgical management. And I hope that this interactive video has been helpful to you. Thank you very much. Bye-bye.